endometriosis needs to be known in a larger scale and need more awareness in Singapore.
I personally did not know about it until I was diagnosed. No one in my family knows about it. None of my friends knew about it.
When I was doing my research and looking at options, looking at doctors, there's still not a lot of information out there.
While I see more people in recent years knowing about endometriosis, I believe there is still a lot of work that we can do to educate the general public and also to promote early diagnosis.
However, I do feel like it's improving. I think especially with the younger generation, I think we're more open to talking about women conditions.
Currently it takes about 8 years on average for women to be diagnosed. So hopefully if all the initiatives being done, we can bring that number down.
The more general public knows endometriosis, the easier for individuals to seek medical help and also receive appropriate treatment.
Awareness is getting a bit more better now with efforts from the public as well as the ads, giving around whereby they are educating people about endometriosis.
I think it is important for us to deliver a clear message to all endo warriors that they are not in this alone. All the friends and families are behind them.
Endometriosis, Namira's charity, I think it's probably one of the more prominent, movement groups out there in Singapore.
I'm actually extremely happy that we have got a big group of volunteers and supporters who are all supporting the awareness of this disease condition.
Good morning, everyone. Welcome to Endometriosis in Asia. When will the silencing end? Our dear moderator, Miss Yasmin, is unfortunately unwell today. She has been down with a high fever and a sore throat, and despite really looking forward to hosting this session, she's unable to join us. We are sending her all our love and well wishes for a smooth and restful recovery. And in the meantime, I'll be stepping in as your moderator for today. Thank you so much for your understanding, and let's continue to hold this space together with the same spirit she would have brought. This event is organized by E4Endometriosis in collaboration with incredible partners from Singapore, Indonesia, and Malaysia, and is being held in conjunction with International Mental Health Awareness Month. This webinar is a historic event, the first cross-Asia initiative led by patient advocates to break the silence around endometriosis, amplify voices, and inspire change. Over the next few hours, we will hear from passionate advocates and expert speakers who will share insights into the physical and mental health impacts of endometriosis across Asia. Together, we will explore strategies for better care, hear inspiring stories, and work towards creating a united voice for change. Earlier, we watched a video about the E4Endometriosis movement and how it has paved the way for advocacy over the past decade. You might have noticed the E4Endometriosis E symbol, a simple yet powerful visual mascot representing empowerment, embracing change, and encouraging conversations. We encourage you to use the E symbol in your advocacy efforts. You can form the letter E with your right hand and share it in photos or videos with the hashtags E4Endo or E4Endometriosis to raise awareness. Whether you are here as a patient, caregiver, or supporter, we thank you for joining us in this journey of understanding, empowerment, and advocacy. Let's make today a meaningful and impactful experience for all. Before we begin, let's go over some quick housekeeping rules. Please switch on your video during the session to promote mutual participation. Stay muted during presentations to avoid interruptions. Remain kind and respectful in your words and actions throughout the session. This talk is intended for general awareness and wellness insights. For specific medical concerns, we encourage you to seek advice from qualified healthcare professionals. We are using Pigeonhole Live to ensure your questions can also be seen on the live stream. Please scan the QR code displayed on your screen to share any reflections or questions during the session. You can also vote for questions you would like to see answered during the Q&A. Finally, this event is being streamed live on our E4Endometriosis YouTube channel. So if you miss anything, or want to revisit the insights shared today, you can always watch the recording at your convenience. Here's a quick rundown of today's program. First, we will hear from myself, Ms. Namira Mohamad Marsudi, the founder of E4Endometriosis. I will be presenting about the movement. Next, we will hear from Dr. Mali, an endometriosis specialist. After which, we will have Ms. Wenny Aurelia, the founder of Endometriosis Indonesia. Following that, Ms. Surita, Mogan, the founder of MYEndosis, will share her perspectives. Then we will hear from Dr. Annabelle, a clinical psychologist specializing in mental health. And finally, we will conclude with a Q&A segment where your questions will be addressed. So without further ado, let's kick off the event with my presentation, and I'll be sharing the slides now. Bismillah. My name is Namira and I am the founder of E4Endometriosis, Singapore's first ACRA-registered non-profit dedicated to endometriosis awareness, support, and advocacy. And today, I do not just speak on behalf of Singapore, I speak on behalf of every person in Asia who has been told their pain is normal. I speak for those who have been passed from doctor to doctor, each visit ending with the same dismissive phrase, just take painkillers. I speak for those who have felt their bodies turn into battlegrounds, fighting a disease that the world refuses to see. But we see them. And today, as we commence this historic event, we declare this together. The silence ends now. 12 years ago, when I first started sharing my story, Singapore was a conservative society, especially when it came to discussing menstruation, let alone a painful, life-altering disease like endometriosis. Talking about period pain was uncomfortable. Talking about menstrual disorders, unthinkable. And yet, in every room I stepped into, I saw the same thing. Women whispering about their pain, hiding their struggles, accepting suffering as their fate. I knew then that if I wanted to change this, I had to pave the way myself. It was not easy. One voice, one story, one fight. The resistance was real. The skepticism was suffocating. But shame has never saved anyone. Silence has never cured a disease. So I kept speaking through doubt, through dismissal, through the endless battle of running into brick walls. I kept going. And I realized something powerful. If I wanted to be heard, I had to find common ground. And that common ground was this: painful periods are not normal. This was the first myth we had to destroy, because for decades, this belief has allowed endometriosis to remain undiagnosed, untreated, and dismissed as just a bad period. But we did not stop there. From there, we challenged some of the biggest misconceptions that continue to mislead and harm patients today. Endometriosis is the endometrium. False. Many people, even medical professionals, misunderstand this. Endometriosis is not the endometrium. The tissue shares some similarities. It bleeds, it grows where it shouldn't, it causes inflammation and scarring, but it is biologically different. This difference is critical to ensuring proper treatment. Hysterectomy cures endometriosis. False. Many patients are told, just remove your uterus and you'll be fine. But endometriosis is not confined to the uterus. It grows outside of it, on the ovaries, bladder, intestine, even diaphragm or lungs. Removing the uterus does nothing if the lesions are left behind. Childbirth cures endometriosis. False. Another dangerous myth. While some women may experience changes, temporary relief due to hormonal changes during pregnancies, this is not a cure. In many cases, symptoms return just as aggressively, if not worse. Menopause cures endometriosis. False. Many believe that once menopause arrives, endometriosis just disappears. But for those who have lived with this disease for years, the damage, scarring, adhesions, chronic pain does not simply vanish with age. As awareness grew, so did our conversation. And around 3 years ago, we started addressing the deeper truth about endometriosis that many still do not know. Endometriosis is not just a woman's disease. Endometriosis is estrogen-driven, and while it primarily affects those assigned female at birth, men can also develop endometriosis, especially in cases of prolonged estrogen exposure. It is time we remove the gendered stigma and acknowledge this disease for what it is, a systemic whole-body condition. Endometriosis can exist anywhere in the body. It is not just in the reproductive disease. It has been found in the lungs, diaphragm, intestine, kidneys, even the brain. This is why we cannot rely on outdated definitions that limit our understanding and treatment. Pain is enigmatic and highly individualized. One of the biggest misconceptions about endometriosis is that its pain is uniform. It is not. Pain in endometriosis is complex, unpredictable, and varies dramatically from person to person. Some with severe stage 4 endometriosis feel little to no pain, while others with minimal lesion experience debilitating agony. This is why pain cannot be the sole diagnostic factor. Patients have been dismissed because they do not appear to be in enough pain or because their symptoms do not match the textbook definition. But pain is personal. This is why we must stop measuring endometriosis by pain alone and push for earlier, more accurate diagnostic methods. The delay in diagnosis, an average of 7 to 10 years globally, is unacceptable. For far too long, endometriosis has been framed as merely a painful period problem, dismissing the profound emotional and psychological suffering it inflicts. As conversations around mental health gain momentum, we use this opportunity to shed light on the deep disparities that endometriosis brings. Endometriosis does not just attack the body, it attacks the mind, the spirit, and the ability to live with dignity. Those who live with it know the truth. It is the anxiety that grips you when pain dictates your every decision, your work, your relationships, your ability to plan for the future. It is the isolation of being misunderstood, of watching your life shrink while the world moves forward without you. It is the emotional toll of infertility, of shattered dreams, of feeling like your body is working against you. It is the weight of repeated medical gaslighting, where your pain is questioned, minimized, or outright ignored, leaving psychological scars that last long after a diagnosis. Some days, endometriosis is not just an illness. It is an all-consuming existence. We cannot speak about mental health without acknowledging the silent suffering of endometriosis patients, their emotional battles, their economic struggles, their fight to be believed, and then there is the financial cost. In Singapore, we see a two-tiered healthcare system at play. Those with financial means can access specialists, get timely diagnosis, and receive expert excision surgery. Meanwhile, many of us rely on public subsidies, where wait lists are long and specialized care is limited. The reality, delayed diagnosis, decades of suffering, patients forced to choose between financial and survival and medical treatment. This is why we continue to push for equal access to care, and the world is finally starting to listen. Just recently, the Straits Times, one of Singapore's most esteemed newspapers, covered our advocacy efforts, bringing endometriosis, infertility, and healthcare inequality to the forefront of national conversation. But a conversation is only the beginning. Today, E for endometriosis is over 2,000 members strong, but numbers do not define us. Our unity does. Over the years, we have forged powerful alliances, particularly with MYEndosis Malaysia, because our struggles, both as patients and as advocates, are deeply intertwined. We share the same pain, we share the same battles, we share the same relentless pursuit of change. And today, with Endometriosis Indonesia joining us, we take another step forward, bringing this movement to the entire region. We are no longer fighting alone. We are no longer waiting for permission to be heard. To every advocate, every patient, every fighter, I see you, I believe in you, and I know how hard this is. I know what it feels like to be dismissed, to have doors shut in your face, to have people frown upon your work, question your credibility, and undermine your knowledge. I know what it's like to spend your own money, your own time, your own energy just to keep this awareness alive. I know, and I applaud you for continuing. To every advocate who has fought for this cause, you are the reason change is happening. To every patient who has had to fight just to be believed, you are the reason we refuse to stop. To every person still searching for answers, you are why we are here today. Because the silence ends with us, and together we will make sure it never returns. So as we begin this historic event, I invite all of you, whether you are a patient, a doctor, a researcher, or an ally, to listen, to learn, and to amplify this message beyond today. Because the fight for endometriosis awareness is not just about today, it is about the millions still suffering in silence, It is about the generations to come. It is about rewriting the narrative of this disease once and for all. Together we break the silence. Together we pave the way, one e-sign at a time. Up next, we have the privilege of hearing from Dr. Mali, an internationally recognized endometriosis specialist and consultant at the Dr. Mali Clinic for Women and Advanced Pelvic Surgery. With over 1,500 advanced surgeries performed by her, Dr. Mali has helped countless patients navigate the complexities of endometriosis with care and compassion. Today, she'll share her insights into endometriosis management and treatment. Over to you, Dr. Mali.
Okay. Hello. Hi, good morning, everyone. Very nice to meet every one of you online. So let me just play. Okay. Can everybody see it? All right. So I'm Dr. Mali from Singapore. I'm an endometriosis specialist. I mean, all of us here have been know that endometriosis is just such a debilitating condition. And what is more frustrating is that although it is so common, but the awareness of this condition, whether it's among public or whether it's among the medical specialists, are relatively low. So great thanks to Namira, to Surita, to Wenny to organize this event, this first ever event in Southeast Asia. Because we've been knowing that in Southeast Asia, there's still a great lack in diagnosing and treatment of endometriosis, and still so many patients are suffering from it without getting the real answers to the pain that they have. So today, we're just mainly focusing on the early diagnosis and early intervention for endometriosis and some of the common myths about this condition. So some basic information here. Endometriosis actually is a very common condition. So it accounts for about 10% of women at reproductive age. And we do realize this 10% actually is still lower than we see now, because I think in the past many years of awareness education, many women do come forward early now. So we do manage to diagnose endometriosis early, but on the other hand, we do see an increasing trend, increasing incidence of endometriosis as well. Then for those patients who are actually go to seek fertility help, for those infertility couple, 30% of them do due to endometriosis. And for those women who have or who suffer from painful period, 40 to 60% of them are due to endometriosis. Although this condition is so common, you can imagine this is an incidence that are quite similar to diabetes condition. But everybody know about diabetes, hypertension, but not so many people know about endometriosis. And why is that? So the awareness of this condition is so low that leads to an average delay in diagnosis of 7 to 8 years from the onset of symptoms, which is a quite sad thing, because imagine this woman, imagine most of the women has been suffering from pain for 7 to 8 years before it finally got diagnosed. So what is endometriosis? So just now, Namira also roughly mentioned endometriosis is different from endometrium. Of course, the cells are quite similar. Endometrium are the cells that are lines in the cavity of the womb. But for endometriosis, similar cells there, but they started to grow elsewhere. They started to grow outside of the womb. The problem with endometriosis is that it have a tendency of bleeding. So it can cause microscopic bleeding. And again, bleeding will cause fibrosis, cause scarring, cause adhesion. With more and more scarring formed, then we can start to see all these changes here. So we can have a cyst in the ovary called an endometriotic cyst. It can also be outside of the pelvic organ, cause all the scarrings as well. So you can see this one is the uterus and cause bladder adhesion. And here is the bowels. The uterus was densely adherent to bowels as well. And in severe cases, it's caused the complete distortion of anatomy. So if you can see here, this is the normal pelvis and the laparoscopic surgery, but this is very abnormal. So all the organs have been fused together, a lot of scarring. So it's not difficult to understand why women have suffered from infertility, can suffer from debilitating pain because of the distortion of anatomies here. So again, endometriosis is much more than just a cyst. So this is one of the common reasons why there is such a big delay in diagnosis, because still many believe that, okay, when we do a scan for women who have period pain, you can see the ovary, there's no cyst in the ovaries, then quite commonly patient were told, oh, you don't have a cyst in the ovary, you don't have endometriosis. This is very wrong, because we know that endometriosis is a condition that can basically present in any part of the body organ. And, and only 20% of patients with endometriosis have a cyst. So if we use the standard of a cyst to diagnose endometriosis, we're actually missing 80% of the endometriosis diagnosis. So why is delayed diagnosis so common? So of course, low public awareness, especially in Asia. We were often told when we were young that, oh, it is normal to have a period pain, and once you get married, once you have kids, the pain will be gone. So many girls have been suffering from pain for years, and then until they get married, cannot get pregnant, then diagnosed as endometriosis, or some of them are lucky enough to have kids, but after delivery, the pain comes back. And then again, there's a lot of symptoms that is overlapping with the other condition, because we know that endometriosis basically can affect many different parts of the body, can affect bowels, can affect bladder. So it depends on the location of the endometriosis. It can have a very similar condition to other conditions, for example, bowel problems or bladder problems, adhesion problem, muscle problems. So there's a lot of overlapping symptoms. Again, in medical professionals, the awareness is still relatively low, whether it's among primary care physician or even among gynecologists. A lot of time, if the doctors are not trained in endometriosis, unfortunately, wrong information are still given to patients. So what is the common wrong information that is given? So Mira also shared some information just now. So I'm sure all these are not unfamiliar to all of you. So a lot of patients were just told, oh, you don't have an ovarian cyst, hence you don't have endometriosis. Oh, your colonoscope is normal. You cannot have bowel endometriosis. A lot of patients who suffer from pain went to emergency department multiple times, had a CT imaging done. Oh, your CT is normal. You cannot have endometriosis. So all these diagnosis dilemma is wrong, because all these imaging are not reliable ways or imaging modalities to diagnose endometriosis. Unfortunately, I will explain a bit more later on. So treatment-wise also, so some of our patients, unfortunately, they underwent hysterectomy and then still having persistent pain, and then they were told by the doctor, oh, you already had a hysterectomy. It can be endometriosis that's still causing the debilitating pain. So things I want to emphasize here is that endometriosis is not only a disease that affects the reproductive organ. It's not only a gynecological condition, because we have to remember that endometriosis can go anywhere. And actually, in my daily practices, 80–90% of the endometriosis are not affecting uterus, ovaries, affecting other parts of the body organ. So it's a complex whole body disease that impacts every single system. It can go to bowel, it can go to lung, it can go to urethra, it can go to bladder. Of course, it can affect reproductive organ. Sometimes can go to the heart, go to the nerve, etc. So why is it so difficult to diagnose? Because the endometriosis, the location is really what matters. So the location is the key. So it depends on where the endometriosis is located, the symptoms can be extremely, extremely different. So that's why when we're talking to fellow colleagues, we're talking to primary care physicians, we always have to emphasize to the points is that whenever you see a patient with pain, regardless of where the pain is, regardless of what kind of pain they have, always bear in mind the diagnosis of endometriosis, because it can have very different types of pain, depends on the location. So we often work with a multidisciplinary team. We're managing patients with pain, of course, with pain specialists, with colorectal doctors, urinary doctors, gastro, a psychologist, then dietitian, pain team. So these are the teams that we often work together because endometriosis basically is not only a gynae problems. So how do we diagnose ourselves early? We always believe in, okay, so to increase awareness, what we have been doing over the past many years is not only to increase awareness among doctors. A very powerful tool is to raise awareness among public itself, because only if the patients are well educated, if we can recognize the symptoms, oh, certain types of period pain is abnormal, we should go to see a doctor early. Then if patient went to see a certain doctor, realize, oh, the information I was given doesn't quite make sense, maybe I should seek a second opinion. So I think over the past 10 plus years of education, awareness among different level, what we realized that actually public awareness is the most powerful tool when it comes to increase the management of endometriosis. That's why we actually design a lot of a self-assessment tool for patients in order for them to recognize, oh, certain type of pain may be abnormal, maybe I should see a doctor. And we also put a lot of education materials online as well to educate our patient, okay, what kind of information is a red flag sign. So for medical professionals as well, when we teach them how to recognize, because understandably from primary care setting, without ultrasound scan, it can be very, very difficult to diagnose endometriosis. But what we emphasize here is to listen to our patients, because the symptoms do give a very, very good clue of the potential diagnosis, of the location of endometriosis. So when you see a doctor, or when you see a endometriosis specialist, rather than just telling them, okay, I have pain, what is more useful is that you can actually have a diary of your symptoms, maybe for the past 1 year. You look back, I mean, patients with endometriosis, we all know that they can have different types of pain. The doctor may not ask, but you can actually prompt the doctor, okay, I have pain, I have a cramped kind of pain, or I have a shooting pain somewhere, I have a nerve pain, I have electrical shock kind of pain at certain locations, or I have pain on passing motion, or I have pain during sexual intercourse, etc. So if we have a very detailed pain chart or detailed pain history, this will be very useful for the doctor to target their subsequent examinations, imagings, etc. So that's why we also designed this questionnaire. So if you look at the questionnaire on the right hand side, this pain chart actually is extremely useful, because we know pain can be anywhere, right? So if we have a chart that you can chart the location of the pain, the severity of the pain, and then the nature of the pain, it will be very useful for your clinic consultations as well. So that's why we emphasize for our patients, emphasize to medical professionals that a detailed history, it is very important. Don't go immediately jump to imaging. Don't go immediately jump to all this fancy MRI, CT. Basically, just listen to your history, listen to your symptoms. If you can have a very detailed history chart, that would be extremely, extremely helpful. So again, there's various reports on the frustrations that our patients do have when we're interacting with our doctors, because it is frustrating for after so many years, although this condition is so common, most of the patients still feels that what matters most is that the doctors need to listen to the patients, because as patients who suffer from pain for so many years, you know your body the best. You know what your body is suffering from, the symptoms that you have, what kind of pain you have. But just have a detailed history chart. So let your doctor listen to your symptoms. So one of the very important red flag sign, I think from all over the world, we know that if the doctor is not listening to you, it means possibly he's not that specialized in endometriosis treatment. Because when we're doing our education, we always tell our doctors, listen to the symptoms, because we cannot presume what symptoms patient have. Listen to patients in every single detailed symptoms that they have. They will give us a very good clue of potentially where the endometriosis could be. So if you look at on the left-hand side, you can see the pain, endometriosis history. Usually we take a lot of history. So each patient that we see here, usually we can take like up to like 40 minutes to 1 hour to manage one patient, basically because we do spend a lot of time screen through all these different types of pain: location, pattern, severity, characteristic, duration of the pain, what kind of pain, whether it's cyclical or constant or continuous, or whether it's random intermittent pain, whether there is any changing pattern, the type of pain, whether it's a non-menstrual pelvic pain, or dyspareunia means that pain during sexual intercourse, dyschezia means any pain during bowel movement, or any other bowel-related symptoms, or dysuria, or bladder-related symptoms. Lower back pain is a very important clue. Lower limb pain, a groin pain, sciatica, or upper body chest pain, lung pain, etc. So all these give us a very important clue of where we target our subsequent examinations or imaging studies could be. So how do we diagnose? So of course, we went through the history. Physical examinations, very important. So when we do examinations, we do use fingers to feel the pelvic organs. Don't underestimate the power of just a simple examinations, because still 80 to 90% of the endometriosis are in the pelvis. So by doing a simple finger examinations, we could be able to feel the nodularities, and also to correlate the specific location of the disease to the nodule as well. So one of the other common myths or mistakes that we used to have is that, I'm sure that all of you were taught before that, okay, laparoscopy is the golden standard of diagnosis of endometriosis, but this is no longer true, because we no longer requires a surgery to diagnose endometriosis. What we use now is endometriosis mapping scan, which is a simple ultrasound scan, but during the scan, we do need to scan for various parts of the body organ for us to have an understanding of the location of the endometriosis. So a trained endometriosis specialist should be able to perform these type of scan. So during the scan, various things that we do need to assess, including the kidney, whether there is any scar, endometriosis, and we can also assess the bladder, ureter, whether there is any adhesion or scarring around this organ. Of course, uterus, ovaries, tubo-ovarian complex, whether there is any scarring around it, what is the situation of vagina, what is the situation behind the cervix, what is the situation of the bowel, what is the situation of the ligament behind it. So actually, all this does comprise a complete endometriosis mapping scan. So this is what an endometriosis mapping scan should look like. So it cannot only be uterus or the ovaries, right? So it should have a very complete assessment of all the pelvic organs for us to understand what is the location of the endometriosis. So if in certain areas such expertise is not available, what should be considered is MRI scan. So again, go back to the myth that we have. Why CT scan cannot diagnose endometriosis? Because for endometriosis, it's mostly a soft tissue disease. So in a CT scan, it won't be able to differentiate different types of soft tissue, whether it's normal soft tissue or whether it's fibrotic or scarring tissue. That's why CT scan, the value of CT scan in diagnosing endometriosis is very, very limited. So even if a CT can be negative, the endometriosis can equally be very, very severe. So when it comes to the imaging for endometriosis, it's always either endometriosis mapping scan, or if the expertise is not available, having the MRI scan to diagnose endometriosis. So when it comes to treatment, it's even more various route of endometriosis, because basically endometriosis treatment is a very highly individualized treatment. Depends on the priority of the treatment, whether it's for fertility or whether it's for pain, depends on the symptoms that the patient have. But there's 3 main arms for endometriosis treatment. One is hormonal, one is surgical, one is fertility treatment. So it could be various combination of these 3 arms, depends on the age of the patient, priority of the patient, symptom of the patient, and the location of the endometriosis. So when we are assessing a patient, it's always important to know, okay, these 3 different arms based on the priority of the treatment. And when it comes to whether it's hormonal or surgical, do discuss in detail of what is the best approach for each individual patient, because at different stage of the fertility life, the aims are very different. For example, when we're dealing with a young girl with no fertility intention yet, versus we're dealing with a couple that is trying to conceive but not pregnant yet, versus we're dealing with patients that has completed family, then the treatment could be very, very different. So that's why the history is important for us to understand what is your treatment priorities and at what stage of the fertility life you're on. So talk about individual treatment. Medical treatment is a hormonal treatment because we know that endometriosis is a chronic condition. Unfortunately, it does require long-term management. It's not like, okay, I give you a few months of hormonal treatment, your pain is better, we stop treatment. So for endometriosis, unfortunately, because it is a hormone-dependent condition, as long as you're not menopause, the ovaries will still continue to produce hormone that stimulate endometriosis to grow. So whether we're talking about starting with hormonal treatment to do, or for those who have completed surgery using hormonal to prevent their chance of recurrence, hormonal treatment is a long-term treatment. Usually we do advise to take all the way until menopause. This is the key, because if we stop hormonal treatment, once your ovary wakes up, start to produce estrogen, again, endometriosis will grow. So, of course, I understand all of us do have a concern about long-term safety for hormonal treatment. And the good news that actually the newer ways, newer hormone treatment for endometriosis, they have been doing a lot of long-term studies, etc. It has been shown to be safe to take in the long run. Of course, even when you're on hormonal treatment or the condition is well controlled, it's still important to have a regular follow-up, because we know that medical treatment for endometriosis is basically to slow down the progression, but it doesn't get rid of the disease. So for certain types of endometriosis, for example, for deep infiltrating endometriosis, unfortunately, some of them do still progress, even when on hormonal treatment, or even when the symptoms are well controlled, the disease might still potentially grow. That's why it's still important to have a regular checkup once every 6 months or once a year to make sure that disease is not spreading to other parts of the body organ. When it comes to surgery, so the treatment is different based on different location of the endometriosis. So endometriosis have 3 different types. So we are talking about endometriosis outside of the womb. So it can have cysts in the ovary, can have deep infiltrating endometriosis, basically can spread to all different organs like bowel, ureter, or causing a lot of fibrosis, can have superficial endometriosis, etc. So it depends on the location of the endometriosis. The treatment, even for surgery, can be very, very different. Another common mistakes, or I would say myth, that people always make is that we're going for surgery for pain, but only the cyst was removed. This is very, very common, unfortunately, but this does lead to a lot of persistent pain after the surgery, because we need to know that the cyst itself, an isolated cyst, without spreading to surrounding organ, without scarring around it, it rarely causes pain. So surgery itself is never about only removing the cyst. If we're going for surgeries for pain, we have to make sure that before the surgery, we know exactly where all the endometriosis are, apart from the cyst itself. We have to make sure that all the deep infiltrating endometriosis are excised properly in order to make sure that the pain is gone. The other myth that always made is that, some doctor would say that, we scan and find a cyst, we're going for surgery. This is also wrong, because right now what we do realize that not all cysts need to be operated, because cyst itself tends to respond to hormonal treatment pretty well. Rather than going for surgery, we can simply giving a few months of hormonal treatment to see whether with hormone the cyst can shrink. 60 to 70% of the time it will shrink. So as long as you don't have pain, your endometriosis hasn't spread to other area, if you only have isolated cyst, start hormonal treatment first. And also do an ovarian reserve test first before you're going for any type of surgery for endometriosis. One of the cases I want to share here is this young girl that we saw. Unfortunately, she had a forced surgery for cyst and pain, but the sad thing is that every time the surgery was done, they just go in, remove the cyst, but the other areas of endometriosis were never touched. So not surprisingly, the surgery not only didn't solve her pain because of the pelvic endometriosis not excised, again, endometriotic cysts have a very high chance of recurrence. So usually after 1 year, the cysts come back again. Persistent pain, cysts come back. Go in one more time, do another surgery, remove the cyst, the pain still the same or even worse. So when the girl comes to see us, she's still having persistent pain. The pain was much worse than a few years ago before the first surgery. And unfortunately, the cyst grows back again. And now she's keen to try for fertility. So we did a scan, realized there's pelvic deep endometriosis. And not surprisingly, there's a recurrence of the cyst, another 4 centimeters. What did we do? We did the ovarian reserve test because we know that if this girl had already done 4 surgeries on the ovaries before, the main concerns here is her ovarian reserve. What is ovarian reserve? Ovarian reserve basically means that how many eggs that are left in the ovaries. For us girls, we were born with a fixed number of eggs, unfortunately. So each month when we're having period, the one batch of eggs would disappear from this pool of eggs. And when this pool of eggs finish, then we're menopause. So we know that age itself, with age, ovarian reserve would be reducing. And also endometriosis itself would also affect the ovarian reserve level. Surgery itself would also reduce ovarian reserve. So unfortunately for this girl, when the ovarian reserve comes out, at the age of 36, he had the ovarian reserve of a menopausal lady. She's ovarian reserve is only 0.2. So we have to break the news telling her that unfortunately, with AMH is so low, her chances of fertility is almost 0. Even with IVF, we do need healthy eggs to get pregnant, to have the eggs. But with AMH is 0.2 pmol, the chances for IVF success is also extremely low, basically because there's no eggs to stimulate from. And in the meantime, she has a recurrence of the cyst, she is still having pain. So that is the kind of situation that we want to avoid for all our patients. We have to emphasize to the fact that not all endometriosis need the surgery, number one. If need the surgery, we have to aim for one good surgery at the correct timing. So these are the information we have been telling our specialists years and years and years. Basically, that's the tragedy that we want to avoid. We don't want to go in surgery too early. Too early, the surgery reduce the ovarian reserve, then fertility will be a problem. Too late, endometriosis spreads to other areas, causing bowel damage, causing kidney damage. That's also something that we don't want. So find the correct timing of the surgery is very, very important. So when do we need surgery? So that's when it comes to diagnosis. We have to do an endometriosis mapping scan to see exactly where the endometriosis are located. Certain location, no choice, really have to go for surgery. For example, if the endometriosis has already invaded into the ureter, causing kidney damage, we cannot wait. And also this type of endometriosis will not respond to hormonal treatment. To avoid organ damage, we have to consider surgery early. Or if the pain is not responding to hormonal, to medical treatment, the girl is suffering pain every day despite hormonal medications, we have to go in early. And also for endometriosis with fertility problems, we have to prioritize, okay, whether this girl is more suitable to go for fertility treatment first, or whether the patient is more suitable for surgery to sort out the endometriosis first, then go for fertility treatment. So there's various factors for us to decide which route the patient will go, especially when it comes to fertility and pain together. So this can be a bit tricky because we know that the treatment for fertility versus the treatment for endometriosis can be very, very different. So that's why it's always important to discuss with endometriosis specialists to see what is the individualized treatment plan for y'all. So when it comes to surgery, what kind of surgery? So I was very surprised when some patient was still told the information that, oh, you have a very extensive surgery, endometriosis, let's go for open surgery. We can see much better with open surgery. This information is absolutely wrong because you can see from the image below that, okay, for keyhole surgery, basically, the camera can go into the abdomen because most of the endometriosis are hiding behind the uterus, right? So if most of the disease are hiding behind, the advantage of keyhole surgery is that the camera can go very low, very posterior, and have a magnified view of all the structures. Whereas you can imagine for open surgery, surgeons' eyes cannot go into the tummy and see all the disease. It at least 30, 40 centimeters away, and it's blocked by uterus. So with this vision, if we cannot see, we cannot excise the disease completely. That's why for endometriosis, it's never been a case where open surgery is better than keyhole surgery. So keyhole surgery, although the wound is small, but the camera can really have a very close view to all the endometriosis disease. So that's why laparoscopy or robotic surgery is always better than open surgery when it comes for endometriosis. So the other thing, I'm sure all of you have heard about the difference between ablation and excision. So what is the difference? So ablation basically means to burn the surface of the disease, whereas excision, we really have to go to the bottom, go to the root of the disease and get the whole nodule out. It's a big difference. Ablation surgery is no longer recommended for any types of endometriosis, basically because it doesn't treat endometriosis at all. The pain recurrence rate is very, very high. And by burning on the surface, it also creates a lot more scarrings again. So not only the pain persists, but usually the pain will get worse after ablation surgery. Although the risk of this type of surgery is low, but it doesn't treat the disease at all. So that's why for endometriosis, ablation is never suggested. Excision, in the expertise in endometriosis specialist hand, risk is actually very well controlled. The risk is still relatively small, but in the meantime, it managed to make us get to the root of the problem, make sure the disease is removed completely. So I will show a few very, very good examples here. So because, for example, these patients, okay, on initial looking, so this is uterus. This is bowel behind. This is tubes and ovary, left tubes and ovary. So on initial looking, we can see, it doesn't seem too bad. The POD is still quite well preserved, etc. But the problem, so if we choose to do ablation and just ablate the surface of the endometriosis here, we are actually missing a big bowel endometriosis. So this patient do have a very severe bowel endometriosis. Actually, the bowel was being adherent to the ligament behind the uterus called uterosacral ligament. So what we really have to do is to separate the bowels away, excise all these endometriosis, and then the endometriosis unfortunately has invaded into the rectum for this girls as well. So we proceeded with a bowel resection. So you can imagine that if we only do ablation and burning on the surface here, we actually are leaving 98% of the endometriosis inside. The pain will never be relieved. This is another case, which is also very good illustration of the difference between ablation and excision. So in a lot of cases, on initial looking, it looks okay, not too bad. There's a bit of endometriosis here. But actually, if we just do ablation, what happens is this patient actually do have a ureter endometriosis. Her kidney has already shown signs of damage before the surgery. We know this patient have a ureter endometriosis. So imagine if we just do ablation and burning the surface, we won't be able to go to the source of the problem. So whatever is in the ureter will still continue to cause damage. So this is the ureter that connects kidney to bladder. So you can see there's endometriosis nodule invading into the ureter. So again, this is after all the shavings and everything. There's still a big chunk of endometriosis going into the ureter itself. So if we don't do excision, this problem will never be gone. So actually, this patient do have ureter implantation just to save the kidney functions. So that's why the excision surgery is always important. A complete surgery to remove all endometriosis is also very important. And the first surgery is always the most important because we trying our best to avoid repeated surgery. So the first surgery, always aiming to do excision, a proper excision surgery with complete excision of all the endometriosis in order to reduce the chance of recurrence for this. What happens if the surgery is incomplete? Of course, not difficult to understand, persistent pain, progression of endometriosis to more severe disease requires repeated surgery. So these are the few cases that we saw before where endometriosis can potentially cause both kidney damage, both loss of the kidney, and it can also go to rare locations like external iliac vein, major vessels, etc. Another myth, I think Mira mentioned just now, hysterectomy does not treat endometriosis. Please remember that hysterectomy only treats adenomyosis, which is the endometriosis inside the womb. But for endometriosis outside of the womb, we cannot only do hysterectomy because it doesn't target the treatment at all. So it will leave a lot of pelvic endometriosis behind and the pain will still persist. So I will just stop sharing over here because endometriosis is just so much things to learn. There's still a lot of useful information online that even before you see a doctor, it will be very useful for you to refer to all these websites. So Singapore, we have our support group. We have Mira had this endometriosis endosupport.sg, which have a lot of useful information on treatment of endometriosis. Worldwide, we have a Nancy Nook endometriosis education, which Nancy do put up a lot of useful information as well. I Care Better is another platform that aims to standardize or find the proper endometriosis specialist. And in the meantime, they do put a lot of useful information on how we manage endometriosis as well. I'm sure in Malaysia and Indonesia, Surita and Wenny are also doing a lot of useful works, put up a lot of useful information. So before you see a doctor, just read all this information for you to understand a little bit more about endometriosis. So when you see the doctor, you are also well prepared. I think together we can still make a difference. I think most important is self-education, awareness. Of course, from medical point of view, we're also trying our best to educate as much doctors on how to diagnose and how to manage endometriosis, how to do early diagnosis. Things to remember, endometriosis is a chronic condition. It requires long-term management. We cannot just after the surgery disappear. And even for doctors, we emphasize the importance of long-term follow-up. Laparoscopy should not only be used for diagnosis because we do have very powerful tools for us to diagnose endometriosis before going for surgery. So timing of surgical intervention is very important because at different stage of life, the aim of the treatment will be very different. Not saying like surgery is the only way to manage endometriosis. We need to find the correct timing to do the surgery. And when it comes to for surgery, do a good surgery. A good surgery is very important to prevent recurrence. And also teamwork is very important. I do believe in collaborating with our patients, with my patients, because it is basically a disease that requires long-term follow-up. So from medical profession point of view or from patient's point of view, we do need to work together for us to get the best outcome as much as possible. So with this, I will finish my sharing. And if you do have any information, do have any questions or anything, don't hesitate to drop me an email, or you can actually contact Mira or Surita or Wenny as well. So we are here all the times to help you. Thank you so much.
Thank you, Dr. Mali, for the enlightening presentation. Really appreciate it. Learning a lot every time I'm listening from you. Okay, our next speaker is Miss Wenny Aurelia, founder of Endometriosis Indonesia. Since 2015, Miss Wenny has built a supportive community of over 19,000 members and has been a relentless advocate for education, awareness, and hope for women in Indonesia. Ms. Wenny, we are excited to hear your perspective. Over to you.
Okay, thank you.
Namira. I want to greet everyone. Good afternoon, everyone. I'm truly honored to be here today among inspiring endocrine advocates across Southeast Asia. Before I begin, I would like to express my deepest thanks to Dr. Mali for such an insightful and compassionate presentation. Doctor, it's always incredible valuable for us, especially as patient communities, to learn from experts who truly understand the complexities of endometriosis. Thank you, doctor, for your clarity. And of course, I want to thank you, Namira, and the team at for Endometriosis Singapore for organizing this powerful session. It's mean so much for us to be here today together across Indonesia, Malaysia, and Singapore with one shared mission. I truly hope this is just the beginning of many more steps we will take side by side in Asia. And I want to greet, is Dr. Annabelle is here. I want to greet Surita Mogan, the president of MYEndosis, and all the endosists are joining us today from Indonesia, Malaysia, and Singapore. Thank you for being here, and thank you for the incredible work you do. My name is Wenny Aurelia, and I'm the founder of Endometriosis Indonesia. Today, I'm deeply grateful for the chance to share our story, our struggle, and our strength as a patient-led movement in Indonesia. Okay, before we go deeper, let me first introduce who we are as community and how we have been working to support women with endometriosis in Indonesia. We are a patient-led community that support women living with endometriosis in Indonesia. Today, we have over 6,000 members on Facebook, nearly 19,000 followers on Instagram, and 3 active WhatsApp group support group joined by 1,000 plus members. Our discussion group focus on endocare, fertility, and lifestyle. And behind all of this, I'm not alone. Today, I'm joined by the incredible core team of Endometriosis Indonesia, my sister in this journey. All of them is here now, right now. Thank you for joining Cici today. They are not just administrator or volunteers. They are endo sister who walk the same path and have this community with dedication, heart, and strength. And if you want to know us more, you can connect with us through our social media website at endometriosis.in-Indonesia. Okay, I wish I could tell you everything about my journey, but we only have a short time today. Maybe next time you treat me a cup of coffee and I will talk all day. So I will talk about my short journey. My journey start in 1997 when I was a teenager. I experienced intense period pain, but everyone around me said that it's normal, and I believe the myth. It will go away after marriage. And after got married, I was finally diagnosed with endometriosis. But even then, the focus was only on fertility, not the disease itself. And one day, I was paralyzed by the pain that was became my turning point. I started looking for answer, joined an online support group abroad, and in 2015, I created a Facebook group just so I wouldn't feel alone. I never planned this. I was courage born from desperation, but that courage became the seed of something bigger. After I create Facebook group, I never expected what would happen next. Every day, someone new joined. We started to connect. We started sharing, and many of them said, "Oh, wow, finally, someone understand me. Someone understand my story and my pain." And the first time, I was the only one helping, but slowly, more and more endo sisters stepped in, not just as member, but as supporters. And from there, I began to see something much bigger. The cases were getting more complex, the questions were getting deeper, and I realized we couldn't rely on personal stories alone anymore. We were all confused, we were all searching for the same answer. From that search, two major challenges became very clear. The first challenge is limited information. Endometriosis is still under research around the world. In Indonesia, the lack of many people, even healthcare and doctors still believe in myth, and when misinformation spread, it complicates everything. The second challenge is a lack of support because the pain is invisible. It shows up differently in every moment, which makes it difficult to explain. Many underserved feel alone even in their own family. They feel like no one believes them. And when you are hurting, confused, and unsupported, you start to think that maybe the problem is you. Okay. Those two challenges limited information and lack support became the foundation of our mission. At first, the group was just a place to connect, but over time you realize sharing stories wasn't enough. What our community really needed was empowerment. And that's when our vision shifted from just listening to each other pain to helping each other rise above it. We focus on three main pillars. First, we empower endometriosis to become a smart patient, like Dr. Mali said, because if we don't understand our own condition, we lose control over our journey. What is smart patient? A smart patient is someone who learns from valid and scientific information. She can collaborate with her doctor, not just follow blindly, and set goals for treatment so she can make decisions with confidence. Second, we build long-term support. We create safe space. We learn to accept our limits and we support research that can bring better care. And the third is we raise public awareness. We work to prevent the normalization of pain, minimize misinformation, and encourage early detection so fewer women have to suffer in silence. With this new mission, we knew we had to take a real action. So over the past 5 years, we have worked hard not only to raise awareness, but to truly educate and support our community. We create a patient booklet with clear, accurate information. We launched our website and built a digital learning platform. We held weekly Instagram live with doctors and experts. I'm joined the podcast with the expert, and we organize offline support group to talk openly about treatment option and emotional struggles. We also brought endometriosis education into school and created self-care and healing spaces through art, sports, and community events. Because we believe that knowledge must not come with hope. Only this long journey, we don't just need answer. We also need space to breathe, to heal, to feel joy again. But we didn't stop there. Then we ask ourselves, is it working? Is it helping? So in 2024, we conducted a member survey and the result touched our hearts. The result is 84% of our members said they now feel confident speaking with doctors. 80% said they made better treatment decision. 83% said they have come to accept their condition with peace. Even doctor began to notice. They told us, we love treating members from your community. They come prepared. They ask a better question. They understand their condition. That shift from patient who used to feel lost to patient who now ask questions, understand the condition, and work with their doctors is exactly what we hope to see. There is a long road to do, but we see a hope in what we are doing right now. And this year marks 10 years of endometriosis in Indonesia. If someone told me back then that a small Facebook group I started just to feel less alone would grow into a community like this, I wouldn't have believed it. We have come a long way. We have cried together, loved, learned, and fought together, and we are so proud of what we have built. But even after a decade, there's still one problem we haven't been able to solve, a problem that still breaks our heart every time we hear it. And the problem is diagnosis delay. Even after all the awareness efforts, it still takes years for women to get a proper diagnosis. In 2024, we conducted again a survey with 153 of our members, and the result was heartbreaking. On average, it still takes about 7 years to get diagnosed.
That's not just a number. That's year of pain, confusion, and fear. Most endosisters waited 5.4 years from the first symptoms just to speak to a doctor for the first time. Then it took another 1.5 years to finally be diagnosed and treated. So we are not just talking about medical delay. We are talking about the lost time, about missed chances, about pain that could have been prevented. And this is what we knew we had to change. Okay, then we decided to act. To mark our 10th anniversary, we launched a national initiative called Gerakan 100 USG Gratis or 100 free ultrasounds. We partner with clinics across 8 cities in Indonesia. Indonesia is a very huge country, and more than 600 women applied. And from them, we carefully selected those who truly needed help the most. But we didn't stop at just giving free scan. We also offered emotional support and gave them a clear diagnostic roadmap through a booklet we created. We called it Panduan USG Diagnosis Endometriosis. This booklet help women understand what to ask during ultrasound exams, what sign to look for, and what question to bring to the doctor. And before this booklet, we already have one, the patient booklet that contain what is basic information about endometriosis, and this is the second booklet. And yes, anyone can download it for free on our Instagram. You can visit our Instagram at endometriosis.indonesia. And for many participants there, this was the first time they feel seen. The first time someone said, "You are not imagining this." Okay. And then after the ultrasound program, we felt proud, but we also knew that this was just beginning, because even after the scan, some women still didn't get the answer they needed. So we asked ourselves, why is delay still happening? And to understand better, we invited 20 women from the program to join a focus group discussion, FGD. And what we heard gave us clarity. It helped us to see that this delay isn't just about doctors or hospital. It's about something much deeper, something rooted in our culture, in our system, and in our emotion. From the focus group, we identified 3 major barriers that continue to delay diagnosis and care. Cultural belief that normalize pain, a complex healthcare system that's hard to navigate, and a mental health struggle that are often visible but very real. In the next few slides, I will walk you through each of these because they are not just abstract issues. They come from real experiences and they shape how endosisters suffer and survive. Okay, let's start with culture. In our survey, 63% of members said they believed pain was normal until they were finally diagnosed. Among teenagers, it was even higher. 87% thought period pain was just something girls had to accept. Many of us grew up hearing the same myth. It will go away after marriage. You are regretting. In Indonesia, we said it lebay. You are lebay. The only married woman should visit a gynecologist. And worse than the myth were the judgment. I won't read each one aloud here, but you can see them on the screen. You can read them on the screen. These are the real words said to real people, words that made our sister feel ashamed, humiliated, and alone. They are powerful, but not in a good way. They hurt, they silent, and that's exactly why we need to break them. Next is the system. Structural challenge. Most endosisters in Indonesia rely on our national insurance, BPJS. It's helpful, but incredibly hard to navigate. At the first level clinic, many women are told it's just a period pain and sent home with painkillers. Some are never even referred for further examination. At second level hospital, it may take 2 or 3 options before someone finally listens and takes them seriously. At top level hospital, there are long queues and sometimes even the necessary medication or equipment are limited. So to get a proper diagnosis and care, you need more than just symptoms. You need to be persistent. You need to be brave again and again. Okay, let's talk about the mental health challenge. You can read on the screen too. These are the real words from our member, and honestly, they are hard to read, right? Some speak of emptiness, some speak of fear, some say they no longer recognize themselves. These quotes reflect something deeper, that endometriosis doesn't just hurt the body, it leaves scars on the heart. It can change the way we see ourselves and how we think the world sees us. The truth is, many of our sisters feel broken long before they ever get a diagnosis because the pain is real, but often so is the silence. And that's why healing endo must include the body and the soul. This finding has sharpened our understanding. We now see more clearly this is not just a medical issue, it's cultural, emotional, and systemic. So after 10 years, are we satisfied? Honestly, no. The deeper we go, the more we realize how much more work we still need to do. Behind every story, there's another layer of pain. Behind every new member, another urgent need. That's why we've strengthened our team, not just survivors and volunteers, but also doctor professionals and professors, people who believe in this mission as much as we do. And we are just getting started. That's why this year we are focusing our energy on 3 directions, not by starting from scratch, but by deepening what already works. First is awareness. We'll continue going to schools because many sisters who reach us already in late stage, they have had multiple surgeries or years of misdiagnosis. We want to reach them before that. That's why we also go into companies, public spaces, even train station and coffee day events to meet people where they are and start conversation earlier. Second is advocacy. Our community has grown so much. In our private group alone, there are over 7,000 members. Our WhatsApp, Telegram groups are full of daily questions, medical, emotional, and everything in between. This year, we'll begin training certified peer mentors. Pray for us. Hope it'll be smooth. So people who don't just listen but are equipped to guide. They'll be trained in medical literacy, emotional boundaries, and how to support others with care and respect. We will begin around 10 to 15 volunteer first. The third is research. We believe data creates change. Indonesia has over 270 million people. If 1 in 10 women has endometriosis, that's million of lives affected, right? Yet we still rely on international data. We hope that by sharing what we have learned and collaborating with academics and institutions, we can spark more local research so our solutions are rooted in our culture, not truly serve our people. Okay, as we wrap up, I want to leave you this. Endometriosis is not just a personal issue, it's a quite painful reality that millions of women live with, especially in South Asia. The pain is real, but so are the barriers, stigma, shame, misinformation, and limited access to care. What we need is not just better treatment, we need better understanding, better system, better conversation, and that's why we continue to speak up. That's why communities like ours exist, because every woman deserves to feel seen, to feel heard, to feel like she matters. And thank you for listening, and thank you for standing with us in this journey, in this mission, and in this fight. I will. This is the end of my presentation. Thank you.
Thank you, Ms. Wenny, for your insightful and inspiring sharing. Really appreciate it. Next, we will hear from Ms. Surita Mogan, founder of MYEndosis, Malaysia's first endometriosis association. Through her advocacy, Ms. Surita has tackled stigma, misinformation, and created a safe space for patients across Malaysia. Ms. Surita, the floor is yours.
Sorry. Okay, thank you so much, Namira. I'm going to share my slide now. I hope you can see my slide. Can you all see my slide?
Yep, it's in good order.
Okay. All right, good morning, everyone, or good afternoon. Okay, so we have started in the morning, of course, and it has been a very, very informative session. And first and foremost, I would like to thank our remarkable endo warrior, Namira, and E for endometriosis for initiating this monumental endometriosis talk. It's truly a very commendable work that you're doing, Namira. And of course, I'm truly humbled by the incredible speakers that we have today, Namira, Dr. Mali, Wenny, and Dr. Annabelle, who will be joining us in a while. So without further ado, I know we're actually running out of time, and I might not want to talk that long. Okay, so I'm going to start immediately and delve into this projects that we're doing in Malaysia in order to create awareness on some of the important aspects that we can do in our own country on addressing endometriosis awareness. Okay, I represent Endometriosis Association of Malaysia. We're fondly known as MYEndosis. As you can see, we are made up of patients as well as caregivers who are driven to change the perception on menstrual pain. So basically, a little bit about myself, which I'm not going to talk much. Well, I myself as a patient, I was diagnosed with endometriosis, adenomyosis, and endometriosis of the bowel in year 2001. And this is after 9 years from the onset of my symptoms. So can you imagine many, many years of dealing with healthcare professionals and even the community, and yet nobody could give me an answer that I need. I did my surgery, laparotomy surgery in 2001 and multiple laparoscopic surgeries that proceeds after that. And the last surgery was in 2012, which is to remove a tumor, the left tube and the left ovary. It was all removed back then. So I was, of course, as a patient on medication, like many patients, we are on hormonal medications. And this is how we manage our condition. But basically, we're still hoping that there will be a cure one day. And of course, let's all work on ramping up research and promoting endometriosis, even among healthcare professionals. My journey on fertility was very, very heartbreaking. It was a difficult journey. For a good many years, I was struggling to conceive. I lost my first baby. I carried him up to 7 months and he passed away. And my second and third pregnancies were all very, very difficult because I couldn't carry any of my babies full term. So enough about me. I'm actually going to talk to represent all the Malaysian patients that we see here. So basically, majority of us go through a cycle of pain. It's not just during menstruation. We experience pain even after our menstruation cycle. And all this, of course, causes extreme mental health challenges. A lot of us do experience chronic fatigue. We can't sleep. We have increased stress and anxiety, depression, and some of us don't even like our own body because when it's flare-up time, we are bloated and we can't fit into our jeans or any of our attire. And some of us tend to wear baggy outfits. So basically, our journey is never ending. And it's not just that particular menstrual cycle, it's every single day. And this is why some of us do isolate ourselves and we don't really want to interact much. And we tend to feel that we want to be alone. So this is the cycle of pain, which I think can be echoed by all of you who have endometriosis, as well as those people around women with endometriosis. They have seen patients suffering as well. So I'm here actually to represent Malaysian women who are experiencing difficulty and frustration. As you can see here, these are two posts in our private group. The one on the right is a patient who spoke about how frustrating it is to deal with healthcare professionals as well. Some of the doctors actually told her that there's nothing that can be done, you know, so this is of course frustrating. And then of course the post on the left is on a patient who had her surgery, but probably still experiencing pain. And when she consulted her healthcare professional, he actually or she actually said, I thought you should not have pain. So basically, these are the hurdles that women like us go through all the time. And we at Endometriosis, we are trying our very, very best at MYEndosis to create that traction, to create awareness, because it's like what Dr. Mali said and what Wenny and Namira said, it's quite common. I'm surprised that we still don't talk about this actively. And we ourselves should do something, even if you're not in the association in your own country, please speak up actively about endometriosis. We have to make this a common address situation so that we can actually reduce the diagnostic delay. So without further ado, I'm not really going to talk about everything because I've actually echoed what Namira and Wenny mentioned, okay, very important information there, but I'm only going to talk about the emotional pain that we see among patients. So as you can see, it's definitely an invisible illness. We all look fine on the outside. That is why misunderstanding tend to happen, okay? So majority of us are handling the internal demons that we have, because sometimes we are unable to concentrate at work. We have missed school days and pain is caused by us unable to work as well. And we do have some point where we are withdrawing socially and we have strained relationship with people around us. So the unseen impact is real. It's not just the physical impact, it's the emotional impact as well. And we don't really talk much about the hidden journey that patients go through. Yes, as mentioned by Dr. Mali just now, patients do go through surgery, but do we talk about the recovery from surgery? Do we talk about the ordeal that these women go through? We don't really talk much. So basically, if you're talking about laparoscopic surgery, it's 1 or 3 weeks of recovery, and laparotomy is 1 or 2 months of recovery. And some of these girls, they do take medical leave, sometimes up to 60 days. Now, we have to understand that exists, and we have to acknowledge their journey. Okay, so a lot of us tend to feel like, oh, you know, once you're have a surgery or once you're on medication, you're fine. Not really, you know. So sometimes women go through this journey and we have to address this hidden journey and acknowledge it. Okay, so as for fertility treatments, they do have IVF and IUI and many other fertility treatment that's available for women who are unable to conceive. But let's talk about the hidden journey. Going through this long, frustrating period of fertility treatment is present. Okay, we have to acknowledge that. And sometimes fertility treatments or even recommendation for patients will not work. Okay, so again, a form of support is needed, and the community around her should support women who are facing fertility hurdles. And like what was mentioned by all our previous speakers, a lot of us do take hormonal medication and oral contraceptive pills to manage our condition, which has been greatly helpful, okay, in order to avoid pain and everything else. But I truly advocate for patients to talk actively about the side effects of medication. And of course, healthcare professionals to also talk about side effects of medication to patients. Because what we see is adherence to take medication is dropping, especially when patients experience some side effects that they consider unpleasant. For example, spotting or bleeding or continuous bleeding or pain even after taking medication, or even weight gain. Okay, some women I know, they are very unhappy that they take certain medication and they gain weight. Okay, so these are things that we have to actively talk about. Don't just tell the patients that they have to take medication, but you need to tell patients that this might happen, this could happen, so that patients are informed on what to do. So that is why talking about the hidden journey is extremely important. We all know that women with endometriosis experience a lot of emotional pain, especially if we talk about the single patients who are not married. Do they tell their potential spouse they have endometriosis? That's a big question, okay? So a lot of times I've seen single patients who come to speak to us and they said they just don't want to reveal that they have endometriosis because they are afraid that nobody wants to be their partner, you see? So these are things that we need to actually create an environment where we can actually engage with patients and give them a hug or just a listening ear, because a lot of times these are challenges that they experience. And for married couples, for those who are facing difficulty in conceiving, that is itself a difficult challenge. And the financial constraint, let's not forget about this. Okay, it's an expensive healthcare to treat endometriosis. Surgery itself could cost a lot of money. And even if you're on medication, it can cause a financial constraint to families that cannot afford. And let's also not forget the period poverty. Even having excessive bleeding and period, you have to actually purchase your pads, and pads are not cheap nowadays, you know. So these are all some of the hurdles that women experience. And some of them are, of course, not ready to get married. And the troubling thing that we see sometimes is there's a tendency to push pregnancy as a medical solution. And we all know as patients, that's not a solution, okay? So sometimes I do speak to healthcare professionals and to inform them that they should speak to patients and not corner them to get pregnant as a solution. So sometimes some of these patients are not ready to get married or not ready to have children. So we have to respect that. And another thing would be being judged at work, even experiencing breakup and divorce among patients. This is all very, very common. We have seen many, many times patients who come to us to speak about their spouses who left them when they're in so much pain. And this ultimately causes depression to many of these patients. So what we at MYEndosis, we are trying to do is we are trying to actually connect with these patients and at the same time work with hospitals. So we are trying to create this patient peer support in hospitals itself. So we have experimented with this monumental event that was held in February at a particular hospital. So what we did was we had breakout rooms where doctors will communicate to a small group of patients, and then we have other groups like healthcare providers who are probably involved in some way. We wanted to create a multifaceted approach to dealing with patients, because dealing with patients should be a holistic approach. So when we talk about healthcare providers, we also want pain doctors to be included, physiotherapists to be included, nutritionists to be included, as well as sexologists to be included, because dealing with endometriosis is not just one approach. And as for the peer patient, we also created a breakout room for patients. So basically, we speak with patients and get them to do some activity. I can show you some pictures. Now, as you can see, the pictures, the smaller pictures on the right, That's a breakout room of the physiotherapists handling patients. And the picture on the left is the breakout room of the doctors conducting their small engagement with the patients. And this is a breakout room of our association, MYEndosis, and our volunteers. We actually got patients to be in the room and get them to do some activities where they use post-it messages and they talk about their coping strategies for handling endometriosis challenges. So basically, that's what we have done so far. But of course, it's not enough. Let's not forget the young ones. Okay, so we tend to deal with females who are older, but we tend to forget the ones who are younger. So this is a very interesting study that was done in Malaysia back and it's in 2022. And this was a questionnaire given to 757 adolescent girls. And believe it or not, 85% of the respondents experienced period pain. 85%, that's more than 50%. And 42.1% experienced moderate pain. 11.2% experienced severe pain. And over 70% complained of tiredness, headaches during their menstruation. And these are all young girls in schools and universities. So can we really ignore this? So that is why our association is trying to create a menstrual health education program in schools. And because we want to address the emotional problems that these girls face when they experience chronic menstrual pain in schools. Now, you can see here that a lot of them miss classes and they have difficulty in concentrating in classes and they fall behind their coursework. And sometimes they are discriminated by people who do not have information on endometriosis. And sometimes they can be discriminated by teachers themselves who think that they are lazy or they are avoiding responsibility. So what we did in our association is we spoke actively in schools and we were alarmed. Actually, a lot of these young girls experience chronic pain and excessive bleeding, and they did not talk to anybody about this. Even if they do talk to their mothers or family members, they were constantly told that marriage and pregnancy will solve their problems. Okay, that's the disheartening thing that we hear from young girls. And this is something that we should not encourage or avoid. So what about the ones who are working? Let's not forget them. Okay, so we have seen many times posts on our Facebook by patients themselves complaining about their ordeal. And of course, how do they manage a 9-to-5 job when they are constantly in pain? And the pain can sometimes happen randomly or sometimes not during their menstruation. Of course, for women who work, sometimes they're okay, sometimes they're not okay. So this is something that we also feel that we need to address because emotional problems do happen at work. How do you maintain a job performance when you're in so much pain? Do you constantly take medical leave? Do you constantly take MCs? And even if you're in so much pain, and even if you go to work, can you actually work? So we realized that there's absenteeism, about 11 work hours that's missing per week, and presentism, meaning they are there, but they cannot work, about 6 hours of loss per week. So this is the reality that organizations cannot hide away from. So we feel the need to talk to employers, and that's what we are trying to do actively. We do speak to employers and we do address menstrual pain in general because we do know that there are people out there who might not have endometriosis, or maybe they have fibroids or cysts or other health, reproductive health issues. So when we talk about endometriosis to employers, we try to actually advise employers to create a menstrual-friendly employment where there's access to private spaces when women are experiencing pain, meaning they can go to a place where nobody else can see them when they're in so much pain, access to toilets, flexibility around working hours, medical checkup given for employees by their employers, And of course, why not create that environment where you provide free menstrual pads, accessible, if in case any of your employees have accidents, suddenly they have menses, and of course, the work from home policies given. So this is how we advise the employers to actually create a menstrual friendly environment. So we also have a gender inclusivity concept here. We want to include men in our conversations. So we actually created a subset group called Endo Brothers. And because we feel that endometriosis, although it predominantly affects women, we should include men in conversations as well. So men play an equally important role as women in coping with endometriosis. And as you can see here, there's a picture of an online event that we did in 2021. It was successful. And recently we had an event on the 17th of May, 2025. It's a transformative gathering where conversation about women's health issues, specifically menstrual health, among men is included. So we actually wanted men to understand and be part of these conversations. But however, convincing men to participate in discussion about menstrual health has always been challenging. Some men feel like they don't want to be included, but as usual, we try our very best to get men in, especially men who want to be in and they just don't know what to do. Okay, so that's what we try to get them involved as well. So the men who attended showed incredible commitment, basically. So what I would like to say is, I hope I didn't talk too fast or too slow. But what I would like to say is, I echo whatever that was mentioned by Namira and Wenny. Let's normalize talking about menstrual health. And of course, let's not trivialize menstrual pain. We really, really need to get this conversation open all the time. And I have my QR code here of our association. That's our website. It has been translated to Bahasa Melayu and of course Chinese language as well. So if there's more information needed about our association, you can always scan the QR code. Now, without taking too much time, and of course giving Dr. Annabelle the space that she needs, I would like to say thank you. And once again, thank you, Namira and E for Endometriosis for organizing this. Thank you, everyone.
Thank you, Surita, for the valuable insights. Our final speaker for today is Dr. Annabelle, a clinical psychologist and a principal at Annabelle Psychology. Dr. Annabelle specializes in mental health care for women, addressing issues like trauma, fertility challenges, and chronic illnesses such as endometriosis. Today, she provides strategies for resilience and explore the mental health impact of endometriosis. Dr. Annabelle, thank you for joining us. Please take it away.
Thanks, Namira. Thank you, everyone, for inviting me into your space. I feel really privileged and humbled to be here. And I hope what I share can be helpful for many. I think first I want to take the opportunity to acknowledge that I'm so grateful and humbled that there's this support system put in place where endometriosis is really a silent and an invisible condition. And not enough conversations have been had or are being had. And that also means that a lot of times then our voice doesn't get heard. And I'm really grateful that there's this space. I don't think that my little bit of sharing today is really going to cover all the breadth and all the experiences that the sufferers experience. But I hope that we can try to pick up some of these principles to see how we can generalize them into our everyday struggles in relation to endometriosis and beyond. So like many of you have already shared before, it is an invisible condition, but extremely impactful. And also you have shared that actually it averagely takes about 6.7 years before a diagnosis is given. And that also means that there's a lot of confusion, there's a lot of loneliness in this experience. There's a lot of what we probably would say gaslighting that would have happened, where people don't understand and they just tell us things like, oh, it'll go away, it's just pains, it's just cramp, why are you so sensitive, why are you so like, just take medicine, just take Panadol and then you'll be okay, everybody has it. So I think the delay in the diagnosis also means that sometimes the symptoms might overlap, sometimes they may be dismissed or unseen. And like the speakers before me who have shared, sometimes unfortunately, healthcare professionals themselves may miss it. So definitely the impact is real, and that's what we are here to talk about today. I also wanted to take the opportunity to acknowledge that I think there are all these lived experiences, and if I kind of group them together and summarize them, we got career disruption. It affects the ability to do the work that we want to do efficiently. I'm not even starting to talk about the expectations we have about ourselves in carrying out our duties at work, but it's just solely if you look at work, it will be disrupted. A lot have fertility worries, and you're constantly in pain and discomfort. I think the other lived experience that overrides this whole thing is that you feel really alone because conversations you have with healthcare professionals or even family and friends, you often get experience of being dismissed, and you just feel very alone in this process. Psychologically, what that means is a lot of times you experience shame and helplessness, which is a bit like what we've also mentioned, right? Some of us might think about, do I want to let my spouse know that I have endometriosis? Is that something that I can say? Or, would my spouse think otherwise of me? And oftentimes women in my clinic room will ask me that question. And one thing I will ask them back in response would be, well, life is filled with challenges. Endometriosis is one of our challenge, and as life persists, there will be more that come. And if your spouse cannot accept and support your health challenge now, the question would be, why would you still want to be with him? Because the choice and autonomy also lies in you, and don't forget that. So don't give away the power of choice to your partner. But if they're not accepting of this, then I think it's a data point for you to kind of think about how supportive or how present he's going to be in my life moving forward. And that's something that I always remind the sufferers to take back the autonomy and take back the choice in making decisions. Definitely, also as mentioned, a lot of women with endometriosis might experience anxiety and depression because of the lived experiences, both told and untold. Well, I wanted to kind of put up this grief, a grief model, because the health loss is real. And in my clinical experience, I have met many sufferers who are very driven, and they are trying to just push through it, whether it's because people are telling them to push through it, or that they are also very sick and tired of this process, that they only know how to just kind of push through it. So it's a very fight or flight response to a crisis. And I either hide and avoid it and pretend it's not happening, but the pain is getting too much, so I need to fight and get through it. But I think this thought about, why can't I just push through it? Why is it's a constant battle? And I want to acknowledge that there's a lot of grief in this. And I wanted to put out this grief model so that we can kind of start to label our experiences. I believe it's only when we are able to label our experiences, our thoughts, then we can actually do something about it and make decisions that are a bit coherent and consistent with what's important to us. So there are 5 main stages in the grief model, notably denial, anger, bargaining, despair, and acceptance. The reason why I've put a star in the middle is because with grief, it's not neat. It's messy. You can kind of jump from one stage to another stage. It's not linear. You don't, unfortunately, progress like school, where you finish primary 1, then you go to primary 2, but you can kind of really jump all over the place. So it's not linear. It's different for everyone. Grief, whether it's about a health condition or grief over a loss of a family member, and with endometriosis, is not just about the grief about the health. It's about grief of identity. It's about a lot of losses, a lot of lost opportunities, loss of your future, what you had imagined it to look like, what you had planned for yourself. It's loss of your preferences and options, and the grief of even your everyday loss of opportunities, like I had wanted to hang out with my friends socially, but I'm in so much pain and discomfort that I would have to give it a pass. So there's a lot of grief in this process. And if we start to identify it, then I think we can start to build a little bit of kindness for ourselves. So the most notable stage of the grief is denial. Whenever we are presented with something that comes as a shock, as a news, like maybe we learn online, we read, then we found out that maybe it's endometriosis, or maybe we hear it from a doctor or a friend, and then we go, this can't be happening. That must be a mistake. Maybe it's just pain. This can't be it. So a lot of us might stay in denial. Some of us might move from it faster. Some might take a bit longer. There is no right or wrong, and there is no fixed time that you should graduate from grief. So the very old school traditional psychology talk about grief is, it takes 6 months to grieve. Please take that information and throw it into the recycling bin, because there's no such thing. Because endometriosis will affect us in different areas of our life, and it affects us differently. The severity, the intensity, how much it affects us, what we value would be different for every sufferer. So there's no such thing that there's a neat timeline, but we want to honor the process that we need to go through. Then after that, we would experience some anger. This is not fair. Why is this happening to me? And then sometimes with the anger, we might think, sometimes my patients say, maybe this is my karma, right? Like I did something wrong. But why must I be punished like that? It's not fair to me. So there's anger. And then there's bargaining that says, if I just do everything right, if I just follow all the instructions, if I do everything that Dr. Mali tells me to do, or I do everything that the website or online tells me to do, then everything will go back to normal. It will go back to how it is. Life will be as per normal. So bargaining is a stage that you are trying to make sense of things. You are trying to you sometimes either talk to people, you find out information, you do your own research, but you're trying to ding dong in your head about okay, maybe if I exert some control, things will change. So you might go through that bargaining phase. Then of course, there will be the despair phase, right? The very depressive, very upset phase where you go, I really don't see an end to this. I don't see how I can live like this. Nothing is getting better. This is my life forever. What's the point? There's no meaning in my life. What am I doing? It's so tiring. And all these statements that come up in our mind. And then sometimes on better days, we may actually have a window of acceptance where we say, this is painful, but I can live with it. And you may have had data points where, hey, it was hard, but I managed it. I lived with it. I did well. And then I can do it again. So these are the 5 notable stages of grief. And I imagine all sufferers usually would go through these 5 stages just at different lengths of time, and you can kind of ding dong. And grief is also really exhausting, because you can imagine that if we progress in school, it's easier to progress from primary 1, primary 2, primary 3, then you graduate from primary 6 and that's it, right? But with grief, you kind of just jump all over the place across this star, and just that change and shift in stages is exhausting in itself. So I really want to invite everyone to practice a little bit of kindness, that the process itself is also exhausting, right? It's not just what you're going through, and we want to honor and make space for that. Okay. So we've talked about the difficulties, and all the speakers before me have addressed a lot of that as well. And I want to acknowledge that you're all experts in that area, because it's something that you are struggling with every day. Well, where I hope to fit the gaps here would be to kind of help us cope with the uncertainty and the grief of the diagnosis. And where I really want to focus on today specifically is really more on our real estate inside here, because how we think about things will affect how we feel and how we react. Okay, and I think that's a statement I really want to let it sit for a while. It's like the way we think about things will affect the way that we feel and the way that we react. And a lot of times, the way we think about things without us even realizing it is by using the words that we use. So, for example, if I say, die lah, sure cannot on, right? Then that's the thought I have, but actually it's the words that I use that are very extreme. And then I would feel anxious, I would feel hopeless, and then I would likely just say, give up. So we want to kind of protect this real estate that we have inside here, because there's a lot of research that that shows, especially in the research of cancer, that our mindset does affect the recovery rate and the experience of the illness. So these are some areas I want to focus on today. So the first thing that I want to invite everyone to try, if you can sit comfortably wherever you are, ideally with your feet flat on the floor, and seated straight and comfortable, I want to invite you to breathe. This is the psychologist's favorite thing to do. We like to ask everybody to practice breathing. And I want to explain why, okay? There are many different types of breathing activity out there, like breathing exercise. This is just one of them, okay? I also want to tell you all that I'm a realist, which means when we are in the red zone, we're really, really stressed, really, really angry, really, really frustrated. I will also tell you that breathing is going to be very limited in how effective it can be to help us. So let's breathe before we get to 100 degrees, right? We want to start to practice the breathing when we are somewhere at 50, 60% of our distress levels. Because at 100, when we want to flip table and someone tells you to breathe, I think you might flip the table in that person's face, right? Because at that moment, how am I going to breathe, right? So breathing is a very helpful strategy because not by choice of ours, it's just something we bring everywhere we go. You don't even have to carry something, you have it with you. So it's a very helpful strategy. And breathing is actually something that needs to be learned. And to truth be told, the first time I actually learned how to breathe properly was not when I was a psychologist, when I was actually trying to deliver my baby and I didn't know how to breathe and I had to learn. And then that made me realize that, breathing is something that we have to learn. Okay, so let's try this one. It's what we call box breathing. You breathe in to the count of 4, you hold, and then you breathe out to the count of 4 and you hold. And the thing about this box is let's try not to be then jagged. So if you think about yourself climbing staircase, we don't want to go pop, pop, pop. We want to kind of go as smoothly as possible with the transition. We want to breathe in through your nose, because when you breathe in through your nose, you take in maximum oxygen and then you breathe out through your mouth. So if you can, I invite you in the next few seconds to just try with me. I will count. And you take a deep breath in and clear your lungs. Okay. And if you can breathe in through your nose, 2, 3, 4, breathe, and then hold, 2, 3, 4, breathe out, 2, 3, 4, hold, 2, 3, 4. Breathe in, 2, 3, 4, hold, 2, 3, 4. Breathe out, 2, 3, 4. Hold, 2, 3, 4. Okay, so the few things there would be, there are a few different types of breathing. You can kind of experiment it. The box breathing is one of it. Don't attempt this only when you're really angry and frustrated. But you want to attempt this when you're somewhere between 50, 60. So you're also teaching your body to self-regulate. And also that each breath you bring in and each breath you draw out, you want to try to see if you can slow it down some more. Sometimes breathing may not help us feel better, but breathing can help us not feel worse. So that's something we kind of want to think about. So I want to move into the real estate here that I want to invite everyone to protect. I think we've got some thinking traps. So these would apply to endometriosis and beyond. And some of the unhelpful thoughts that inevitably come up from the clients that I see would be they say, I'm not normal anymore. I'll never live normally again, right? Like this is the end of it. Like forever my life is going to look like that. So I think if I label that, it's a very catastrophic thinking. And if we think about catastrophe at its worst and at its end, more often than not, we will actually start to feel even more anxious, even more stressed, even more depressed. That will affect the way that we can react to it. Another one that comes up quite often is I'm useless. I can't this, I can't cook, I can't look after my family, I can't work. I'm useless now. I've got concerns whether I can have babies. I'm useless. So oftentimes that comes up as well. Very all or very nothing, very black white thinking. And the last one is it's my fault. It's my fault. It's my karma. It's me. It's because of me. Right. So I think these are some common unhelpful thinking traps that come up. And I would invite all of us to try to reframe that. Firstly, I always ask myself, right, when I have a thought, how helpful is it? So I don't even go with right or wrong. Because actually, in that moment when I'm very stressed, I'll never live normally again feels true. But actually, what's the evidence that it really is true? But at the moment, we don't have enough blood pumping to the frontal part of our brain that helps us think. All the blood is, going to the feeling part of our brain that is just saying danger, 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 danger. And the example I often tell people is like when we are overwhelmed with emotions, it's a bit like you walk into a lift and someone farts in the lift. And then the whole lift smells, right? Next time you walk in the lift and someone fart, you're going to think of me already. Because the whole lift will smell and then you cannot function properly. You cannot think properly. You're holding your breath, right? It's a bit like that. When we're overwhelmed with emotion, we cannot think clearly. Everything becomes blurry and foggy. And whatever that is not true feels true. So I don't ask myself whether it's true. I will ask myself, is this thought healthy? Is this thought helpful? Helpful or healthy means, does it help me feel better or help me do the things that I do? If it doesn't, right, I'm going to make an intentional decision to take it away, right? I can't forget about the thought. I cannot stop thinking about the thought, but at least I'll make a decision first to take the thought away because it's not helpful. Okay? Then I want to ask myself, what's the evidence? What is the evidence that I will never live normally again or that I am useless or it's my fault? What is the evidence? Have you looked at data points? What do you even mean when you say I'll never live normally again? Never is very catastrophic. What's normal? Right? All of us will have different types of challenges and then we adjust according to the challenges and we live to the best of our ability with the challenge. But what's normal? As a psychologist, I get asked a lot. I want to be normal. I also don't know what's normal, right? Then another question I find to be quite helpful to challenge those thoughts would be, what's the worst case scenario? So really like, if you really cannot live normally again, actually what is the worst case scenario? And inevitably, a lot of my clients will say, I just find another way, right? I'll just figure another way, like it would just be another way. So is that really the worst case? And sometimes I actually have one client who was able to tell me back that actually I realized that this was a very good challenge, that it was a data point for me to assess if I want to marry this man, because if he cannot support me here, then next time when we got life challenges, how? So like, to the earlier example I gave you. So she's like, okay, so even though it's painful and there's a lot of challenges that come with it, it also helped me pick my spouse a bit more carefully. It's a data point. So that sounds to me to be quite a healthy, helpful thought that she can do something about. And then the other thing is about learning how to build our psychological flexibility. So I've got 6 tips as to how we can try to rewire the way we think about things. So one is, I think we sometimes forget to be in the present moment when we are overwhelmed by our stresses and we're overwhelmed by the unhealthy thoughts, the thinking traps that we have. We actually are quite dissociated from where we are, who we are with, because we start living in our head, but we are not really living in the moment. And maybe just coming back can be quite helpful to just ground us back. Like just, if you feel quite disconnected, even just touching the chair or putting your toes into the ground or touching your clothes or giving yourself a hug can kind of bring you back to the present moment. Or if you have like things that you can hold, like stress balls, gum, hand gum, things like that, by just bringing you back. And our brains are not trained to be like that. Our brains are like bullet trains, right? To keep us safe, they will think about worst case scenario in the future. Then they will ruminate about things in the past that didn't go well for us. But then that's too much information for our brain to deal with. So being in the present moment means, okay, in the future, wait, in the past already. Okay, let's just see here and now, what can I do now to get through now? So that will help to relieve the stress or the things on our plate or the unhelpful thoughts that we are holding on to, so it becomes a bit more manageable to deal with the here and now. The other thing I want to remind everyone is thoughts are thoughts. They are not facts. Other people's opinions are also at best opinions. They are not facts. Other people's judgments are their personal judgments based on maybe, you see, people who make these comments about endometriosis more often than not do not have a solid understanding of the topic itself. They don't actually even know enough about the condition. So they are telling you based on their very limited, one-sided perspective. And that is still their opinion. And you're right, social media also influences what's normal. And then we got algorithm. You're exactly right. The more you see all the unhelpful things, the more unhelpful things come out, and then they become the truth. So thanks for that, Fadia. And I want to remind everyone, thoughts are just thoughts, right? So whether it's somebody else's thoughts, it's still thoughts. They are not facts. If it's my thought, it's still my thought. It's not fact. Fact is backed up by true actual data, right? So maybe we can learn to put a bit of distance between our thoughts and actually the present moment, right? So for example, when I think about I am a failure, I am useless, right? This is the end of it. That's very different from saying, if I put a bit of distance and I say, I am having the thought that I am a failure, right? We are putting a bit of distance. Actually, we have a bit of time. Can we do a bit of a small little experiment here to exemplify this? Okay, I'm going to get everyone to have really toned arms in the next few minutes, so be prepared for that. What we're going to do is, if you can put your hands together in front of your face like me, like that. And I want you to think about your worst thought you have about yourself when it comes to your endometriosis, right? And then as close to your face as possible. And imagine the worst thought you have is written on your palms and is right in your face. And note how you feel about that. Okay? Also note that when you're doing that, you probably can't see me, and you probably can't reach out for your cup of tea if you're thirsty because your hands are occupied. Okay. Now I want you to push your hands as far as you can and as straight as you can. So all the way, hands straight. You cannot bend, no cheating, cannot bend, but hands straight. And so it looks like that. And the thought is still here, but you're pushing it as far as possible and you're keeping your arms straight. So the thought you have about yourself, about endometriosis, is still on the hands. You're still looking at it, but you're pushing it as far as you can. Don't relax your arm. It must stay straight. Okay? And in that time, maybe you can see a bit more about what's happening in your life, but you still cannot drink water. And are your arms getting tired and sore? Yeah. And it's still there, the thought. Okay. What I'm inviting you to now do is put your hands down either on the table or on your legs. The thoughts are still there, but relax your hands and take a cup of water and drink and, do things you want to do. So I suppose the activity behind this is to help us understand that if our thoughts are right smack here, it's hard not to see it as facts. A lot of us try to push it away, right? And just push through it, get on with it. But that itself is very exhausting, and it still doesn't allow us to do the things we want to do. But if we put it down, then our hands are free to do whatever that we want to do, because it is just a thought. It is a thought. And I can still do the things I want to do. Okay? The other thing is to recognize that you are more than your pain and your diagnosis. I think sometimes when we are overwhelmed with it, especially when we feel a lot of pain, it's very difficult to divorce ourselves from the condition, and it almost becomes our identity. But maybe if we can take a step back and say, I have this condition, but I'm also a sister, I'm also a friend, and I'm also whatever your occupation is. Pain is a part of me, but it doesn't define me. It's not the whole me. I am not endometriosis. I have endometriosis, but I am these other things. So this will help to reduce the real estate, that we pay attention to the struggles that we have and to get a bit of balance with everything else that's happening in our life. One that is quite difficult. So earlier when we saw the grief model, there was a part where we talk about acceptance and what acceptance look like. So the best way I would describe acceptance is it is what it is, which is it's not tolerance, it's not resignation. A lot of times, maybe COVID is a really good example. Remember the time we had COVID and we had to wear masks? A lot of us would have been complaining because it's hot, it's humid, it's uncomfortable, but we still have to wear because it's legally mandated as well. Then there are some of us who just, okay, I have to wear, then I wear, and then I get on with things. And you don't really have any feelings that you have to deal with. Another really good example is for those who wear glasses or contact lenses. Do you kind of wake up and every day you put on your glasses, you go, really hate wearing glasses? Or do you not even really have anything and then you just wear it because you need to correct your vision? Okay, then that's acceptance that you need glasses to correct your vision, and acceptance that you need to wear a mask during COVID period. And we want to try to build on that, right? Acceptance that I have this condition, and it accompanies it with people's lack of knowledge and understanding, and there is distress around that. There's a lack of support. And I accept that this is what it is, instead of like avoiding it or building a lot of suffering around that, which is when we don't accept something and we, for example, wish that somebody else understood it or could be more supportive, and they are not, that expectation often ends up in more suffering than we already feel. So if we can kind of accept that, okay, it is what it is. I have this condition. I do my best according to the values that are important to me to work through this. And I need to build support systems that are meaningful and helpful to me. So maybe I cannot expect everybody I meet to understand this, but the people who are in my most important circle, okay, they need to understand this, and how can I work on that? So that brings me to point 5 and 6. Values. What's actually important to us? So think about, maybe a way to think about values would be you turn 70 and then you have a birthday party, and then at that point we are too old to invite people that we don't like, right? So only the people that we like the most come to the party. And then somebody goes ding ding ding, I want to give a toast to you, and I want to tell everybody what I think of you. What do you hope that this person will say about you is probably a good kind of question to start to think about what values are important to you. So what you hope this person will say is different from what you think this person will say. So for example, if you hope to to hear that, example, Annabelle was a dependable friend, she was there when I needed her, Annabelle was kind. Example, if those things are things you hope to hear, that will suggest that these are values that are really important to you. So in your everyday here and now actions, how are you putting those values in place? For example, if kindness is an important value, are you being kind to yourself when you start to beat yourself up about these expectations and these unhelpful thoughts that you have about yourself? Or are you practicing kindness to yourself to acknowledge the pain and distress and allow yourself to rest when you need to? So values can be a bit of an anchor point to help you think about what's important to you and then how to make decisions that are in line with that. So for example, I can make committed actions and take little small steps, right? If I acknowledge or if I recognize that I've got all these unhelpful thoughts, I think of all this and then I'm not getting appropriate support. But being kind is important. Being kind is not just being kind to other people, it's also being kind to yourself. And then how can I be kind to myself? Right? I can allow myself rest. I can acknowledge the distress around the pain and the disappointment I have regarding the people around me about their lack of understanding and support. But I can learn to take back what's within my control, which is what I do. So maybe a committed action would be, in line of being kind to myself, I'm going to stop telling myself that I'm useless. I'm going to stop to catastrophize. And I think I would need some rest, right? I want to go and do something that is kind to myself, some kind of self-care activity that honors what's important to me. So then you can take committed action. Another thing that I will share would be about self-compassion. I think generally in my experience with my women with endometriosis, a lot of them speak very unkindly to themselves. So it's not just about all the things that you are experiencing as a result of the endometriosis that is painful. Actually, what I'm focusing on today is all the thoughts you have inside here that is destroying your real estate. And I think more often than not, self-compassion is missing. So remember, the words you use will affect how you think about yourself and how you feel, and whether that will empower you to take steps forward or backward. So speak kindly to yourself. Allow yourself and honor the distress and the grief that you experience and the feelings that you have and the days that are difficult and bad. But also speak kindly to yourself means, what would have been some kind things you have said to your friend that you like? And then why don't those things apply to yourself? And can you try to say those things to yourself? Okay. Another thing that I find to be quite helpful is to write a letter to yourself from your compassionate self. So the kind you is writing something to the mean you, right? And the key words here is to write, because a lot of times the writing helps you transfer the information that is very messy and chaotic here, helps you organize that onto a piece of paper where you can tangibly see. And when you can do that, then it's easier for our brain to work through that. The last thing I will offer would be to consider visualizing a loving support. So, and this is something I do for myself. When I have very difficult moments in my life, or sometimes when things get really hard, I imagine my hands to be my grandma's hands. And they are the most loving hand to me. And then I'll put it around myself and give myself a hug. And imagine that she's sending me compassion and love and support. And don't underestimate this or how cheesy it may sound, but all of us need to be cared for and loved. And this is one way that we can express love to ourselves. All right. I've come to the end of my sharing. before I go, I wanted to get you all to kind of think about what was that one unhelpful thought you had this week, and how you can then challenge that thought. What value matters most to you? So start thinking about your values and just micro shifts, right? What is one small shift you can commit to trying this week in changing the way you think about things? And with that, I will pass it back to Namira for question and answers. Thank you.
Thank you, Dr. Annabelle, for the insightful presentation. We will now move into the Q&A segment. I will share the Q&A panel. Dr. Annabelle will need to leave us pretty soon, so probably if she can, try and answer, take in one question before she leaves. Let me share the panel first here, questionnaire panel. So, yeah, this is the first one. I think this is for Dr. Annabelle. Do you believe that time truly heals all wounds? For many living with chronic conditions like endometriosis, that idea can feel unrealistic or even dismissive. What's your perspective on healing when the pain, physical or emotional, doesn't fully go away?
Well, my take on that is I don't believe that time will heal. I think that is what we do with the time that will determine if it will heal. If I spend the next 20 years of my life thinking the same unhelpful, toxic thoughts, no amount of time is going to make me feel better. And if anything, is actually going to make me feel worse. So it's kind of what we do with the time that is going to determine what happens. And I think that needs to start with us increasing awareness of how we think about the challenges that we have around endometriosis, the thoughts we have about ourselves, what is pain and what is suffering. So pain is not by choice, right? By sheer diagnosis of endometriosis, it comes with pain, physical pain, emotional pain, as with any sufferer with the diagnosis will experience. So that's not exchangeable. But suffering is what we add to the pain. So suffering is when we don't accept that we have the diagnosis, we don't accept that we need to make changes, we kill ourselves again and again over the thoughts that we have without trying to get a balanced perspective. And while that pain is unmanageable sometimes, the suffering compounds that. So if we can start to be more aware of the way we think about things and to work on that, then we can reduce our suffering and then we have more bandwidth to deal with the pain. So I think that's my take on that. I don't think time will just naturally heal the pain of the condition, but it's very important what we do with the time. It's a bit like if I just have a seed, I need to water it and look after it for it to sprout, and not just kind of leave it to its vices without looking after it and throwing rocks into it.
Right. Thank you so much, Dr. Annabelle. As you can see from here, we have a lot of questions, and it's keep on coming. We might not be able to address everything, so we will be addressing it separately on our own accord. We will try to do that, no promises. But just as mentioned earlier, unfortunately, Dr. Annabelle will need to leave us quite soon. Probably before you go, is there any final words, Dr. Annabelle?
You are not alone, and there is support. The understanding, meaningful support out there. Like we've got Namira, for example, and we've got friends in Indonesia, Malaysia. I think most importantly, when we think about support, is always about finding the right kind of support. So don't give up if we talk to someone who's not understanding and not supportive. Don't give up. It just means it's not right fit. And then we go find somebody else. But you're not alone.
Thank you so much, Dr. Annabelle. Really appreciate it. And we hope that, if there is any concerns at all, if you want to reach out to Dr. Annabelle, her information is actually available in the e-booklet, which we've sent you, which we've emailed you, all the participants. So please do check out and reach out to her as and when you feel that you need somebody to let you know or assist you when it comes to emotional or mentally mental concerns that you have. So please do reach out to her. Thank you again, Dr. Annabelle. We might only be able to answer one more question. I know that the next question is addressing to me. I will answer that separately, but I do want to go on with the next question here, which is, hi leaders, does your current country currently have any government-led initiatives or a dedicated outreach department specifically focused on endometriosis awareness, education, and support? If not, what kind of efforts or structural support would you like to see from the public healthcare sector moving forward to better address the needs of those affected? Maybe we can start with Surita from Malaysia, MYEndosis.
Oh, that's a very difficult question. And of course, thank you so much, Namira. And I truly believe that we need a group of people handling this, you know. And currently, of course, in Malaysia, I can only speak on behalf of what's going on in Malaysia. We do not have a concrete government-led initiative for an outreach program and even a particular department specifically focused on endometriosis. But I do see that some hospitals are trying their best. They have created endometriosis departments that specifically handles endometriosis patients. So there are some initiatives that's scattered here and there, but not really a concrete government-led initiative. I think we have a long way to go, but we're not going to give up. And from our side, we are trying our very best to start chapters in hospitals. So by starting chapters in hospitals, we hope to work closely with healthcare professionals who are supportive to our cause. And hopefully, eventually, we will have a country-led environment where every hospitals have their own support chapters, MYEndosis support chapters. Yeah, that's from my answer. Hopefully, it's an answer that it's acceptable. Okay, go ahead, Namira.
Yeah. How about yourself, Wenny? Endometriosis Indonesia.
Okay. Okay, thank you for the question. Yesterday, after I read this question, I called one of the committee in OBGYN organization like Hiberi, and he helped me to prepare this answer. So the answer is, in Indonesia, we don't yet have a government-led initiative that's specifically focused on endometriosis awareness, education, or patient support. Most of the efforts so far come from professional OBGYN organization like Hiberi and Pogi, who hold 2 to 3 times seminar at a year and regularly update clinical guidelines. The latest was in 2024. But when it comes to public awareness, it's still very limited. It usually only goes out through medical social media, and that's just not enough, I think. So here, what we hope to see from a public healthcare system moving forward, I think one, menstrual health education for adolescents. Many of us had symptoms since our teenage year, but we didn't know what was normal or not. If menstrual health become part of school program, young girls can recognize red flags earlier and feel safe to speak up. And when both girls and boys learn about it, it helps reduce the stigma too, right? And the second is training for primary care doctors and midwife. A lot of patients are still being told it's just a period pain, like we told again and again. That's where delays begin. With proper training at the first level of care, like here we call puskesmas, we hope patient can get referred faster and don't have to suffer for years without answer. Three is better referral and treatment access in public hospital. Right now, endometriosis care is mostly centered in big cities. We need more trained doctor and clear care pathway so patients in rural areas aren't left behind. And four, I have 5 points here. And the four is national insurance like BPJS should cover endometriosis care. Many treatments like laparoscopy or hormone therapy are not fully covered or hard to access due to referral limitation. We hope endometriosis can be recognized as a chronic condition with support through PPJS so women don't go broke trying to get help. The fifth is mental health support. Endometriosis affect more than just the body. Chronic pain, fertility struggle, being dismissed, it's very exhausting. We hope mental health and emotional support can be part of the treatment too. And the last, formal collaboration with patient communities group like Endometriosis Indonesia have insight from the ground. We are not here just to share story. We are ready to be part of the solution. If we can, working together, we believe real, lasting change is possible. Thank you. This is my answer.
Thank you, Wenny. All right, I guess left with Singapore. I'll be speaking on our perspective here in Singapore. In 2021, I actually had the opportunity to speak with representative from the outreach department of one of our government health agencies here in Singapore. And from that conversation, I learned that there is no dedicated department focusing solely on endometriosis. Their ongoing national campaigns tend to center around what are currently seen as pressing public health concerns, such as diabetes, under initiatives like Screen for Life. So for context, Screen for Life is a national health screening program in Singapore that offers subsidized checks for chronic diseases like diabetes, blood pressure, and certain cancers. And it reflects the government's priority in reducing long-term healthcare costs and mortality through early intervention. Now, this naturally raises the question, why isn't endometriosis considered a pressing concern? And the uncomfortable truth may lie in the lack of national data. In Singapore, we simply do not have comprehensive statistical figure to show the scale of the problem, how many are affected, how their lives are impacted, and how this contributes to wider issues like our declining birth rate. And I have knocked on many doors using the low fertility rate as a compelling reason why endometriosis awareness must be addressed at a national level. But without a solid local statistics to back those claims, it is a struggle to get traction. So the next question is, where do these numbers come from? And the answer is research. But that opens up another issue. Why is there so little research? From my conversations with researchers in this field, the barriers often comes down to lack of funding and limited awareness. When a condition remains poorly understood or seen as niche, it is difficult to attract investors or secure public funds for large-scale research studies. But should we wave the white flag just because it is hard? Absolutely not. If anything, I think this should push us harder to amplify our narrative so loudly and consistently that ignoring us becomes impossible. And I have said this before in many of my sharings, and I'll say it again here, changing societal norms takes time. And it wasn't that long ago when the idea of women entering the workforce was radical. In Singapore, it took decades of policy, public education, and social restructuring to normalize that. Think also about other revolutions like the acceptance of mental health as a legitimate health concern. That took generations of advocacy. So I understand what we are doing now, the talking, the advocating, the sharing may not bear fruit immediately. I may not even be around to witness the systemic change I dream of, but the point is this: change will only happen if we speak up now. And not just once, but repeatedly, loudly, and unapologetically, because while our pain may be invisible, our voices should never be. So that's my take on this question. And unfortunately, we are running out of time. So thank you all for your time and participation. And if you have any inquiries, please feel free to reach out to the speakers directly through platform shared in your e-booklet. as we close our session today, before we bring this powerful session to close, we'd love to invite few final words from our speakers, words that may stay with us long after today. Dr. Mali, maybe we'll begin with you.
Yeah. I think there's a great effort for all of you, Mira, Surita, Wenny, to organize everybody together to talk about the issues in Asia. I think we have to be positive and believe there's a hope and there's a solution to the problems that we have. Yeah, and the efforts of raising awareness will be ongoing.
Next, we'll go with Wenny. Any final words?
Because at the end of the day, every woman deserves to be believed, understood, and treated with dignity, no matter where you live or how much you can afford. That's kind of healthcare system we are fighting for. Stay healthy and stay fabulous. See you next time in this event. Hope everything goes smooth. Your treatment, everything you plan, every issue you plan to treat, and I wish you a healthy and beautiful life.
Thank you, Ms. Wenny. Surita, any final words?
Yes, okay, so thank you so much for this. And I think moving forward, let us all work together. I think we all have similar issues in our own country, and collectively we can make these changes that we need so that the younger generation of young women will not go through what we went through, the period of darkness in the past. So that's my take-home message. Thank you.
Thank you, Surita. All right, and I guess let me end it with our next session here. A big thank you all again, all of you as well for joining us in this historic moment. We hope today's session has brought you comfort, understanding, and inspiration. If you found this session helpful, we are thrilled to invite you to the next quarterly Zoom event. Now, this upcoming virtual talk will take place in August. You know of someone struggling with chronic pain related to endometriosis? Don't miss this insightful session with Dr. Diana Chan, a leading chronic pain specialist. She will explore the diverse pain presentations of endometriosis beyond the pelvis, why some pain treatments are effective while others aren't, practical, holistic pain management strategies, and a live Q&A for your question. Similar to today, this upcoming virtual talk is free, but registration is required as slots are limited. Registration is now open, so simply scan the QR code on the screen or visit e4endometriosis.eventbrite.com. This is just the beginning. Together, we have taken a step towards breaking the silence, amplifying voices, and fostering a stronger, more supportive community. If you would like to revisit today's session, it will be available on our E4Endometriosis YouTube channel. Thank you again for being here, and we look forward to seeing you at future events. Take care, stay empowered, and have a wonderful day. Bye-bye.
Bye.
Bye.